Good evening, everyone. I'm Dr. Rahul Pandit, and you're watching the 591st non-stop edition of Dr. KK's Med Talk Show. Let's have the headlines of the day. Britain has ended all COVID-19 restrictions, including self-isolation for people with COVID-19 and free testing as a part of the new Living with COVID strategy. All COVID restrictions will end in England on Thursday, and free mass testing will stop from 1st of April. The Drug Controller General of India, DCGI, has granted emergency use authorization to Biological E Limited for the use of its COVID-19 vaccine, Corbevax, in children aged between 12 and 18 years. After nearly 50 days, the active COVID-19 cases in the country are below 2 lakhs. India's active case load currently stands at 1,81,075 cases, and the test positivity rate is only 1.24%. Delhi recorded 360 coronavirus cases and 4 deaths in the last 24 hours. The positivity rate is now less than 1%. With administration of 35.5 vaccine doses in the 24 hours, the cumulative COVID-19 vaccination coverage in the country has now crossed a whopping 175 crores. Let's have the topic of the day, which is long COVID. And I would like to introduce my friend, my mentor, my elder brother, who is along with us right now for this show. Who is joining with us is Professor Dr. Shashank Joshi. Namaste, Professor Joshi ji. Professor Joshi is a Padma awardee. He is very, very senior endocrine specialist who has got numerous publications to his name. He works with Lilavati Hospital and he's been the Dean of Indian College of Medicine as well in the past. He has essentially been the face of the Maharashtra COVID-19 task force, and his insights into the whole COVID-19 problem actually led him to be invited by the Honorable Prime Minister to the Man Ki Baat show. So, Professor Joshi, thank you very much for allowing me to start the show today. And that brings me up to the topic of the day, which is long COVID. And a lot of people talk about long COVID. And we know that long COVID has been there as an entity identified quite early. And in fact, I am in Australia right now, and I was speaking with a few of my Australian colleagues here, and they are all looking up towards India to teach and to lead the way in non-COVID, because they are not seeing a lot of non-COVID here. The overall cases in Australia are very low, and the overall recognition of non-COVID has not been a big factor in this country at all. So my question to you is: we saw long COVID during the first wave, which was the ancestral strain wave. I was myself having some symptoms of long COVID in terms of insomnia for some time. The Delta wave particularly gave rise to a number of other problems, which we will talk about. And now the Omicron wave, which is going on. What is your analysis? आपकी ये तीन वेव के बीच में की लॉन्ग कोविड के बारे में आपकी क्या टिप्पणी होगी? तीन तीन वेव की अलग अलग, शायद थर्ड वेव जो अभी है उसके बारे में हमें पूरी जानकारी नहीं होगी, क्योंकि अभी 2 ही महीने हुए हैं चालू होके, पर पूरी 3 महीने की टिप्पणी जरा आप बताएंगे.
So, धन्यवाद राहुल जी. First of all, I must thank Dr. KK Med Talk show for having me and Rahul ji on this show. We all know Dr. Rahul Pandit is a world famous critical care expert who practices out of India and Australia. He is a leading faculty both in Mumbai, several universities within Mumbai as a professor emeritus, as well as a leading professor in Australia, in Sydney. He is a chief of critical care in the Fortis group of hospitals and has been a member of the Supreme Court Associated COVID National Task Force, as well as an active member of the Maharashtra Task Force. So Rahul ji asked a very pertinent question. Was there long COVID? What is long COVID and how is it different in each wave? So long COVID means symptoms related to COVID which persist for at least 120 days after the COVID virus has been shed out. Usually it is an immunological reaction or inflammatory reaction. Nobody knows why long COVID happens, and in the course of the today's show, we will discuss depth and detail of long COVID. So in the first ancestor of the Wuhan strain, we did not have medicines. We did not know what we were grappling with. And as you rightfully said, people were having neurological syndrome, which was mental health and neurological health, including insomnia, lack of sleep, restlessness, panic attacks, depression, mood swings, even simple memory loss and brain fog. Those were the common neuropsychiatric syndromes which are associated with long COVID, which last often beyond 3 months, 6 months, 1 year, and 2 years. The most common syndrome in that category was persistent fatigue. I still have patients from the first wave who still come to me with persistent fatigue and tiredness and a feeling of drained out phenomenon. Then, of course, we had cardiac sequelae, we had neuroinflammatory sequelae, we had aches and pains, we had heart sequelae, but lung fibrosis, where you got breathless, asthma, or COPD like symptoms, or heart related symptoms like fast heart rate, palpitations, and as well as heart disease, including heart attacks and sudden deaths, were a part of the long COVID syndrome of the first wave or the Wuhan wave. That time we did not have very strong antiviral drugs to kill the virus. And the virus elicited a very strong immunological response. So this is the genesis of it, that the biology is when the virus attacks our body, our immunity reacts. There is a normal reaction and an exaggerated reaction. So long COVID is supposed to be a delayed, exaggerated reaction of our body's immunity after the virus has gone away. So in the second wave, which was the more sinister Delta wave, we were again hit by long COVID. Again, it was neurological, cardiac, pulmonary, and others, in which there were a lot of micronutrient deficiencies, like vitamin D deficiency, various other micronutrients, including selenium, zinc, etc., were drained out or depleted. Macronutrients like proteins were depleted. And at the same time, we got neurological, psychiatric, cardiopulmonary issues, and even hormonal issues, including diabetes, including thyroiditis, including adrenal gland being inflamed. So these were the common syndrome which was seen post-Delta. But one of the common features which occurred both in first and second wave was lack of taste and smell, and a feeling of persistent giddiness and dizziness. So a lot of patients as a part of long COVID syndrome felt persistently giddy, or they felt persistently their head spinning around. And this was something very common. And many of them were not able to retrieve their taste or smell. And I still have many patients who have abnormal smell or no smell. And I still have many patients who are not getting complete taste, or they are not able to taste food appropriately, or taste only food partially. In the Omicron world, Dr. Rahul was very right that we are only in the second and third month after the Omicron. But clearly there is a long COVID syndrome, predominantly brain fog, memory loss, and a feeling of fatigue. So brain fog, memory loss is a very common syndrome. And Dr. Pandit did an original observation when Omicron started, that the likelihood of heart attack or strokes went up because the blood and the platelets became sticky, or the blood became more thick, which is called coagulability. And therefore, there is a need in the long COVID syndrome not only to give appropriate micronutrients, macronutrients, but also maybe a low dose antiplatelet agent like aspirin. So this is the summary, that first wave, second wave, and third wave. The first and second wave had a very strong long COVID association. Third wave also is having some long COVID association. Usually the long COVID is associated with the severity of the disease. So if you had asymptomatic disease, mild disease, moderate disease, severe disease, very severe disease, or critical disease, the people who are hospitalized, they had a larger impact with long COVID. But as the pandemic has evolved, the long COVID incidence came down, particularly after vaccination, and particularly in the third wave. This is an observation we have all seen, and this is something which is there. So Dr. Pandit, I would like to ask you a question, that as we are evolving in the pandemic, and as we are closely seeing that the pandemic now is in its final stages, where there is a good possibility that the world may be disruption free. In absence of a new variant of concern, we see reasonable hope and reasonable brightness that we might be seeing that. My question to you is, now we have many more tools to handle the virus and boost the immunity. To boost the immunity, we have micronutrients and vaccine. And to kill the virus, we have oral tablets like ritonavir boosted therapy, like molnupiravir, like remdesivir. So, do you think that these therapies have reduced the incidence of the long COVID? Because a lot of asymptomatic and mildly symptomatic people were not treated at all, and they are the ones who are having this lingering phenomenon or this chronic phenomenon of long COVID. So, Dr. Pandit, my question to you is that do you really feel that the modern advances in COVID care and COVID management, including vaccination, have impacted the outcome of long COVID? And what is your Dr. Pandit's perspective of this whole syndrome of long COVID? Is it all in the mind, or is it body and mind put together, or is it a little bit of both? And who has more mind, less body, more mind, or more body, less mind? How do we balance this whole long COVID syndrome?
So, sir, I think it's a very interesting question because most of these drugs which are there, which we have been using right from the early stages when we actually went on to use lopinavir, ritonavir, and now we have got a lopinavir, ritonavir boosted medications coming up. They are all protease inhibitors. So, this protease inhibitors actually brings down the entire um, duration of the viral activity significantly to a few days rather than a 7 to 10 days phase which we were talking about. And every time we go down on the activity of the virus, so does the inflammatory phase also becomes blunted. And if our inflammatory phase is going to be blunted, you obviously will not get the same amount of activation of your immune system, or your inflammatory cascade may not actually go across and cause these chronic protein releases in the body, which will then cause a lingering amount of chronic fatigue syndrome, or maybe some people may have myocarditis, some people may have insomnia or a brain fog. Now, I firmly believe that the introduction of these medicines, and as it got better and better, actually brought down the incidence of long COVID quite significantly. Initial observations were that in the first wave we did not have a lot of medicines. Second wave, as the remdesivir became a prominent feature in the therapy, we did not see the same amount of patients coming in the second half of the second wave. First half of the second wave, we actually had significant number of people following up with long COVID. The second half of the second wave, we did not have a lot. And Omicron, from whatever 2.5 months worth of data which we have now, we started seeing cases in Mumbai from 20th of December. Today is 22nd of February. So it's exactly 2 months. And a month before that, around 17th, 18th of November, we had the first cases coming up in Botswana and South Africa. The talk about long COVID has gone down significantly. I would like to bring across three recent publications in the last 1 month, which have come. The last one being, I think, in Annals of Medicine or somewhere, where they have looked at patients who had COVID and went for a routine surgery. There was a significantly decreased outcome in terms of mortality as well as morbidity in patients who went for a routine surgery within 8 weeks. Mind you, 90% of the data is from patients who were from Delta area. We have not really looked at Omicron right now. So this data may be completely irrelevant in 6 months' time. So I think there is a phase of COVID which lingers around even sub clinically, which we may not be aware of. And when you trigger that immune system with some amount of surgical stress or anesthesia stress or pain or medications, it may actually trigger something which may not be expected as an outcome in surgery or anesthesia. And I think there is a clear data right now that Delta patients who went in for surgery within 8 weeks actually had a poorer outcome as opposed to patients who waited for 8 weeks or more. So I think that's where the distinction is. But as I said, this data may be completely irrelevant in 6 months' time because Omicron may not have a similar sort of a presentation, we just don't know. So I think medications helped. I think our promptness in treating them helped. Unfortunately, those patients who never received any treatment, or the other extreme, so those who never received any treatment were the mild or the asymptomatic one. And the other extreme, which were the critical ones, who were in ICU, who were on ventilator, unfortunately, they had a lot of neuropsychiatric complications. And the neuropsychiatric complications that is rightly mentioned by you, sir, were from simple fear and nightmares to people having brain fog. I've described on one of our Marathi shows before that I have one of the registrars who actually could not interpret what was shown on the monitor. She would keep on looking at the monitor but was not able to actually decipher the numbers correctly. And it does happen really. Some patients do go through a lot of a difficult time. But here there is a silver lining, sir. I think majority of the patients, and I would like to put that number closer to 100%, 98, 99%. If they think that this they can overcome this, they are able to overcome this. They do not require a lot of medicines or psychological help. Some people do require medicines and psychological help, but 98, 99% of the patients, it's a short-lived thing and it gets better very quickly. Yes, some of the things like taste, acidic taste or loss of smell may linger around for a long time. But apart from that, I think most patients are able to overcome the neuropsychiatric complications quite well. That's my reading. I might be wrong because none of us are neuropsychiatrists and we may not be seeing those patients routinely, but a routine COVID follow up patients are not doing that. That brings me to a question to you, sir. Would we describe complications like myocarditis or resting tachycardia syndrome or maybe this anosmia and insomnia maybe as complications of particularly long COVID, or they are associated with any severe viral illness? I think our readers need to understand that can any virus trigger this or it has to be only a COVID virus? Because that question actually came to me from one of the patients who I did a throat swab and proved that patient has not got COVID but has got influenza A and came back with symptoms of long COVID. So that's I would like you to sort of make it simple for our listeners.
So, Rahulji, that's a very good question. And it is presumed that a lot of viral illnesses cause a post-viral prodrome or a post-viral debilitating long hauler. So, the original name for long COVID was long haulers or long-term ailments of survivors from any viral disease. So, these type of symptoms have been described, including the etiology of viral encephalopathic syndrome or chronic fatigue syndrome for a very long time. So, there are 4 or 5 types of long COVID. One is, of course, long COVID. Second is hospitalization related complications like multi-system inflammatory disorders or Guillain-Barré. Then Dr. Pandit, you are into intensive care, so I'm going to ask you something called as PICS, post-intensive care syndrome, where people go into that. But in the long COVID space, the myocarditis, etc., are not very prominent. So the typical definition of long COVID is persistent severe fatigue, headache, and brain fog, which means mild subjective cognitive impairment for at least 4 weeks after acute illness and is independent of the severity of acute illness. So that is the most classical definition of long COVID. So 3/4 of the patients who are hospitalized with COVID have at least one ongoing symptom for 6 months after their acute illness. And this was originally found by Huang et al. In China. He published in the Lancet that people had fatigue 65%. They were breathless 1/4. They had sleeping difficulty 1/4. Anxiety and depression 1/4. Hair loss 1/4. Smell disorder 1 in 10. Heartbeat beating fast or joint pain 1 in 10. So those were it. 1 in 5 patients not requiring oxygen still had a poor lung function even after 6 months. So if you did the Dr. Pandit's popular 6-minute walk test, at least 1/3 of these people, they failed the 6-minute walk test. And therefore they had a lower limit which was there. And if we did a pulmonary function test, the DLCO, which is the diffuse capacity for carbon monoxide, was less than 80% of predicted in more than 50% of the cases. Also remember, a lot of people had prolonged symptoms even if they had mild COVID. Almost 1/3 to half patients had persistent symptoms which appeared and resolved, and many of these resolved after giving the administration of the vaccine. the commonest symptoms, like for example, France reported the first cases and Salman Siron's group reported way back in 2022 non-hospitalized French patients. And they found that fatigue and muscle weakness, sensory disturbance, chest pressure and pain, breathlessness, palpitations and tachycardia, which Dr. Pandit you described, cognitive neurological disorders, taste and smell disorders, and other neurological syndrome was described in France. So the key points are that new persistent symptoms last for 4 to 6 months, regardless of the acute episode severity. In addition to respiratory symptoms, people have fatigue, sleeping difficulties, depression, anxiety, and neurological dysfunction. And therefore, they need a detailed examination. We need to hear them carefully with a lot of empathy. This is really the key in treating the long COVID, because long COVID has challenges. So we have seen this persistently, and the lung also. What you said is very correct, that post-COVID lung disease, some of them have persistent interstitial disease. Some people may have radiological abnormalities. So fundamentally, when we are looking at a multi-dimensional concept, we have some physical issues, but there are also mental health issues. There is pain, there is emotions, there is depression, and all these are there. So in the post-COVID syndrome, there are a couple of things. One is actual physical symptoms. Second is function of the day-to-day quality of life is impacted. Third is neuropsychiatric symptoms. And fourth is situational overlay. So obviously you need to carefully observe them, carefully supervise them, and try to put them into a concept. Now in the neurological and in the cardiological space which you are asking, there are some clear-cut entities post-COVID. For example, neurologists have observed 4 major things with COVID. Number 1, strokes. Number 2, an entity called COVID encephalopathy. Number 3, Guillain-Barré syndrome, which is like a paralytic attack. And 4th is ADEM, acute disseminated encephalomyelitis. Similarly, cardiologists have described basically the whole syndrome of heart attacks, the heart beating fast, rhythm disturbances, and myocarditis. And all this has been very well documented and very well there. So I will give you an example from a neurological standpoint. I saw a woman recently who was 42-year-old, no medical history, had COVID now in December, was sick for almost 1 week with fever, muscle pain, headache, and anosmia. Was not hospitalized and was feeling quite okay, but every time she was having a trouble with short memory and focus. And she continues and she has resumed work, but she can't cope up. And on physical exertion with exercise, the fatigue worsens. All the time she feels that her body is having tingling sensation, and it is worst in the hands. And the heart rate, palpitations, and shortness of brain is seen. So this brain fog is the commonest symptom, with short-term memory, concentration, and word finding and speech difficulty.
Yes.
So, and these symptoms fluctuate. So there is a good day and a bad day. And they are oftenly linked to the fatigue, blood pressure going up and down. And sometimes they can work, sometimes they can't work. Sometimes they sleep well, sometimes they just can't sleep. And eventually they are associated with a lot of trauma. So this is something which we see. Many people get headaches coming and going. Headache has been very common post-Omicron. And that headache has almost, I have referred patients to headache specialists, including migraine experts. Many people get tingling numbness and paresthesias. Many people get dysautonomia, which means blood pressure and heart rate, lightheadedness, palpitations fluctuate. So these all neurological syndrome are very common. But more than just the brain and the neurological syndrome, one entity has been described in the COVID space, which Dr. Pandit you mentioned, called POTS. POTS is postural orthostatic tachycardia syndrome. And another syndrome described is MECFS, myalgic encephalomyelitis with chronic fatigue syndrome. So a lot of these syndromes have been described post-COVID, and therefore we need to understand that low blood pressure, fast heart rate, headache, fatigue, paresthesias, brain fog, all of them are seen. So you need to assess the symptoms, assess the severity, look at comorbidities, look at impact of symptoms on ability to work and daily living, look at focal neurological deficits, and always look at the thyroid function. I always do that. Look at sleep and mood, look at B12 and D3, look at other diseases and other micronutrient deficiencies, look at diabetes, and sometimes we do even imaging status and neuropsychological testing. So that's all we need to do, including sometimes cardiac evaluation. And then obviously we need to address each factor, but very important is also to improve their mental health and sleep hygiene. A lot of people have become sleepless, and that's also become a very, very important thing. So it's very important to reach out and listen to the patient and remodulate them. So Dr. Pandit, I have just given you an overview of what's happening in long COVID space. But lot of people after COVID are out of breath. They need oxygen. They need to see a lung specialist. They need to see a lung physiotherapist. So I would like you to deep dive into the lung, heart, and the more serious elements after COVID in the long COVID syndrome, and how does one take care of them?
Thank you, sir. I think the lung is the most important part, and of course, because lung and heart work in one circuit, they both get affected when one of the organ actually has a problem. So what we have seen is that some of the patients, unfortunately, get a very, very severe involvement of the lung, and that involvement of the lung leads to almost concretization of the lung tissue, and they have a very tough time in recovering from this. So many of these patients who become have very stiff lungs, which are not able to ventilate and oxygenate, land up on high flow nasal cannulas, non-invasive ventilators, or sometimes on a ventilator. And then the recovery process is very, very slow. They require oxygen at home. They are in a debilitated state. They have gone through a lot of post ICU syndrome problems, which you mentioned. There are reasons for post ICU syndrome problems. One of the reason is a heavy dose of sedation, which is required often to be given to these patients because they require to be ventilated effectively. If we don't sedate them and take over their breathing completely under our control, we may not be able to oxygenate them well, and they may actually not get benefits of the ventilator. So that's unfortunately one of the things which we have to do. That leads to two things. One, it leads to a loss of sleep wake cycle. So you don't realize that the patient does not realize whether it's day or night. All of us have a sleep wake cycle where we sleep for 7-8 hours in the night, wake up, and we are fresh for the day. The body demands that. But when you just don't know what is happening because you're put to sleep with medications, that cycle is lost. The brain does not process it. That's what happens first. Secondly, you are not eating through your normal hands and mouth. Your sense of touch, smell, um, salivation, hunger, everything is now being replaced by tube feeding. So a lot of that then plays up into the mind, and along with that, your medications, your steroids, your electrolyte imbalances, they all lead to what we call as an acute confusional state, which may last for several days. And when the patient is taken out of intensive care because the patient does not require any intensive care therapy, just a little bit of window to be looked at, relatives surrounding them, they turn around very quickly and they start feeling better. But the patients who require oxygen at home require a lot of work. They need to be seeing a pulmonary therapist, and I'm not talking about a pulmonary specialist, I'm talking about a pulmonary physiotherapist. They will require to do deep breathing exercises. They will require a lot of physiotherapy to help them clear their secretions. They would require task-based improvement in their lung volumes. So the incentive spirometry may not be very easy for them to achieve above 1 liter, which is bare minimum for most of us. So they need to go with the task-based achievement of that lung volumes, and that often happens with physiotherapists giving them different ways of concentrating on their inspiratory breath and breathing out. And those techniques involve locking your tongue against the soft palate sometimes while you are breathing out, or sometimes when you are breathing in, you hold the breath as long as you can so that your lungs slowly start to become more and more elastic and start becoming more and more compliant with the air. These therapies are often associated with a side by side understanding of the patient's gas exchange. So, if the oxygenation starts to remain stable on a particular flow of oxygen, you start decreasing the oxygen which is given to the patient, and you would see that over a period of few months, the patient comes off oxygen. This needs to be done under the supervision of an intensivist or a physician or a respiratory physician who understand these dynamics. At a point where they are around 2 weeks, 2 months, or around 8 weeks to 12 weeks down the COVID pathway, you may actually get a formal lung function test done, including DLCO, to see what their lung volumes actually are and how much is the carbon dioxide and the carbon monoxide diffusion which is happening. Now, why to wait for 8 to 12 months? Because many of our Indian hospitals unfortunately do not have the disposable mouthpieces which are used, for doing these respiratory mechanics. They use the mouthpieces by sterilizing them. And I would strongly suggest that with COVID 19, anything to do with breathing in and breathing out of the machine is better to be done after 8 weeks, so that we are sure that there is no shred of virus which is going into the machine. So I think 8 to 12 weeks is a reasonable target to look at. Similarly, don't forget your other component in the circuit, which is the heart. When the lung goes through a tough time, your right heart, which actually pumps blood into the lungs, is not used to pump it against so much of pressure. So the right heart also undergoes a lot of change in these 2 months, 3 months time, and we need to make sure that the right heart is coping up well. And I always I'm just going to give a little fun part to the right and left heart. The right and left heart are like husband and wife of the body. The left heart is always strong and muscular. The right heart is always slim and slender. The left heart is slightly taller. The apex of the right heart is slightly shorter than the left heart. The right heart pumps the blood into the body, and when it is pumping, it also helps the right heart to pump it into the lung because they share a common wall. But the most important thing, if the right heart fails, left heart will not be able to function at all. So just like the lady of the house, if she is not supporting the man of the house, nothing happens. But if the left heart fails, it doesn't bother the right heart. Right heart keeps on functioning. So right ventricle is a very important part of the heart, and you need to assess the right ventricle quite well. And I always give this analogy of husband and wife, where if they have to work together, if they have to live together, both of them have to work together. And if not, the right heart can keep on functioning. Right heart will not bother about the left heart, will keep on functioning. The left heart will not be able to function well. So just go to your normal physician, get an echo done, make sure that your heart is functioning well as well. So last question from me to you, so that you can give your gist of the whole show of how we look at long COVID from here on, and what you expect in the next 2 months when this Omicron will be gone, in context of long COVID. I'm not asking you to give any other predictions. In context of long COVID, what do we expect in the next 2 months?
Rahulji, you are asking a very relevant question. I'm already seeing a lot of cases now in our day-to-day office practice with persistent fatigue, brain fog, anxiety, sleeplessness, restlessness. I'm seeing a lot of patients who have fast heartbeat or palpitations, fast heart rate, and low blood pressure. I'm seeing a lot of patients with giddiness. I'm also seeing a lot of patients who have persistent muscle pain, aches. I'm seeing a lot of cases who just cannot do their day-to-day functioning and they have become dull. And a lot of these need mental health and physical health improvement, micro and macronutrient correction, and many a times medical therapy. I'm also seeing a tsunami of cases where heart disease has gone up, coronary artery disease, cerebrovascular disease. I'm seeing the lung disease also going up. I'm seeing diabetes, thyroid disorders, adrenal disorders going up. And I'm also seeing a huge mental health pandemic. So I'm seeing both a physical and mental health pandemic, and I'm seeing a lot of new diseases coming up in this next 2 months of Omicron wave. So definitely Omicron has almost hit every household across the world, but has left some aftermath in the long COVID space. So go to your doctor and go to a mental health expert. Be cheerful and positive. Get yourself screened for micronutrients like B12, D3. Get yourself screened for thyroid, diabetes. Get your heart and lungs checked out, and ensure that you are with appropriate lifestyle, including diet and exercise, appropriate yoga asanas, appropriate positive health attitude, and many medications, including nutrient connections, including B12, D3 supplementations, coenzyme Q corrections. Many of these newer agents have been used, including ashwagandha. They all may have a role in boosting up the immunity. And it's important also to recognize that if you need any precautionary dose or an extra dose of the vaccine, take it, because clearly it impacts the incidence of long COVID. So from a COVID standpoint, we must be vigilant. We need to have a multidisciplinary approach, both of mind and body, both of nutrient and non-nutrient, both of medications as well as supportive care. And we have to swim out of this long COVID syndrome and learn to live with COVID in a more apt way. So, Dr. Pandit, my last question to you, and we will wind up, is that how do we see long COVID? Because long COVID is an ill-researched entity. So, where are we headed on the long COVID space? And what is your final take-home message for all of us from Australia? We are looking forward to welcome you soon in India next week.
Well, I'll be back by the weekend. So thank you very much, sir. And I look forward to be back as well. I think long COVID requires a lot of structured research to be done. Some unfortunately, a lot of money and resources have been diverted towards making people better from COVID, which is what it should be, because COVID is acute, is a more dangerous disease. But now that we are actually coming out of COVID, now that active cases may not require that many admissions, I think we need to have a structured approach towards this long COVID in terms of research, so that we can actually find the right answers for the patients who are suffering this. And we just don't know whether this is going to be a short-lived phenomena, or it is going to be something which they will keep on experiencing for a long time. Also, we don't know whether it is a one-off thing. Some of them may get better, but next time maybe a normal viral infection of any other RNA virus may actually trigger this phenomena again as well. So we need to be very, very clear that we need to have medical answers for these patients. And to have medical answers, we require research collaborative. What better place than India to do it, where we have like millions and millions of patients. So some form of a structured research going into long COVID to identify the problems and find solutions for them. My last advice, as we all talk about every time, sir, COVID is definitely going away, but it will not disappear. That means that you have to keep up with your COVID appropriate behavior. A bare minimum is a mask of a good quality of surgical mask, or two double masks when you are stepping out of the house, and maintain social distance as much as you can. With this, thank you very much, sir. Your last words, and we close the show.
Mask, vaccinate, be cautious, be careful, and learn to live with COVID. Don't ignore long COVID. But there's a lot of hope, less hype, and we are there to take care of you. We will meet once again next week for our Jopas show. But I'm sure that there is a very wonderful Dr. KK's Med Talk coming up tomorrow. Thank you, everybody, and stay safe, stay healthy, stay happy. And we are looking forward to see Dr. Pandit back home in India very soon. Thank you very much.
Thank you, sir. Thank you very much. Good night.